So today it's going to be short and sweet. Today I just really want to talk about, first of all, what pain is. Dr. Pearl, a few months ago when she was speaking, she kind of tapped into pain a little bit, and it just kind of made me start thinking about pain and, making sure that we as practitioners, we're really thinking about what pain actually is, because it's kind of a couple different things. And I think, all of us, we're all dealing with people in pain every single day. And I think it's easy to kind of get wrapped up in that and hearing people, complain about their pain all day, but really are we thinking about what it is? And then I just wanted to kind of touch on what's happening in a chiropractic adjustment, a manipulation, for those practitioners that don't really understand what's happening. That way, when you're referring to us, you can kind of get a sense of what we're trying to do down in our clinic. Okay. So pain, kind of going off of that. What is pain? We all know it's subjective. Patients are coming to us and they're giving us some sort of pain rating of where they're at, but they're 5 out of 10, they're 8 out of 10. It's different than my 5 out of 10 or 8 out of 10, right? So it's really subjective. It's really hard to measure. But there's really kind of two parts of pain that I think it's important to remind ourselves of what's going on. It's really a perception, and then there's the act of nociception, which really isn't pain at all. So for those that don't know the difference between the two, nociception, that's more of what's happening on a neurological level, okay? So in the body, we have receptors all over that are telling our brain that we're having some sort of environmental stimulus. So in the body, there's these nociceptors, the pain receptors, and they are fired up when there's a noxious stimulus or something that should theoretically give us some sort of pain or discomfort. Now, there's a couple different scenarios that can happen. We can have this nociception, this act of it getting fired, and it's traveling up the spinal cord to the brain, and then we're having an equal and adequate perception to that nociception. Oh, that hurts, or that's hot, things like that. Or we can have this nociceptive event, and it's not so discomforting to the patient, and we don't really get that perception. Or there's, extreme cases where people they can have nociception. They don't really realize what's happening is hurting them. Sort of like in diabetics, when they have more of this end stage neuropathy, with their feet, they don't know that something's hurting them. And then there's this perception. So people can have a perception of pain without there really being a nociceptive event. And I think we see a lot of that in our practices where people are having this great perception of pain, but why? They don't really have anything super to suggest that they should be in all this crazy amount of pain. So that's when we kind of have to get a little more creative and figure out, well, why are they having this huge perception of pain? Is it really that they've got something going on that's creating the pain structurally? Do they have more of a neuropathic pain thing going on? Do they have some sort of sensitization going on in their peripheral central nervous system? Or are they depressed? Are they having some sort of psychological thing going on that's altering their perception? So I think it's just important to kind of remember that there's all these different scenarios that can go on, and we kind of have to meet the patient where they're at. And obviously, we know MRIs, X-rays, those don't lie. Those types of tests, they don't really lie. So if there's really something going on, we should be seeing an adequate perception to that. And then there's many players that are involved along the neuraxis as far as this nociception goes. So just kind of a little neuroanatomy for those that aren't familiar with it. Like I said before, we have all these receptors that are picking up this noxious stimuli. That signal is going to travel up all these very small, unmyelinated, and what that word means for those that don't know, uninsulated fibers. So if you think about wiring in a computer, we've got wires that have insulation and wires that don't. And those ones that don't have insulation, the signal doesn't travel so well because there's not that insulation to kind of keep it together. And that's going to go up the spinothalamic tract in the cord, and it's going to go to our sensory homunculus, which is literally just a map in our brain of our whole body. And like I said, we should have that adequate perception. So I want to talk to you kind of how the chiropractic adjustment, what's kind of happening more on a neurological level, and really what we're using to our advantage when we're doing an adjustment, because I think a lot of times people think it's this anecdotal thing, and it works sometimes for some people, it doesn't work for other people, which is true. There are some cases where an adjustment isn't going to work right for that person. Maybe they need something different. So what we're working with and what we're largely playing off of is the pain gate theory. So this is a theory that was founded in 1965 by Melzack and Wall. And basically they discovered that we can have this blocking locally, segmentally, of pain fibers. So we talked about before how those pain fibers, they travel up these small, uninsulated fibers. So the signal's really slow because of that, and it can get lost along the way. But what's really cool about that is we can wake up this other system, these mechanoreceptors, these large, we call them large diameter afferents. And really what that means is that these are thick fibers that have a lot of insulation around them. So that signal travels really, really fast up to the brain. You wake up one of those mechanoreceptors and your brain knows you're moving, okay? So it's all those receptors that tell us that we're moving, where we're at in space, somebody's touching us, things like that, pressure. So when we can get those firing, then we're going to start to see where it's going to block these small fibers and block that signal. And what's really cool for us as chiropractors is that those mechanoreceptors, they are so heavily populated in the joints along the spine, okay? There's a lot more in there that just simple movement can't really tap into. And that's why we get a deeper movement with an adjustment, and it really wakes them up. So these high velocity, low amplitude adjustments, what they do is they activate all of these receptors, like I said, that can't be fired by just a normal movement of the spine. Okay? And then that stimulus, because it's so many at once, we call this summation, it sends a novel stimulus up to the brain. And it starts to activate that sensory homunculus, that map. It activates the prefrontal cortex. And then we start to see over time, when we do this repetitively, we see some neuroplasticity instead of some habituation, which is a good thing. We need neuroplasticity to create change. Without it, then people would just be stuck in this pain pathway for the rest of their lives. So we need this neuroplasticity. And then from there, it starts to activate descending pathways that are going to start to block pain in a different way, which is cool. So we'll talk about that in a second. So just kind of some research that's, they've been working on lately about trying to figure out what parts of the brain a manipulation will light up. So they're actually doing studies now where they're hooking up electrodes to the brain to see what parts of the brain are we lighting up when we do an adjustment. So we've got it narrowed down that we're starting to light up that sensory motor area of the cortex, and specifically we're lighting up the prefrontal cortex. So we're having an effect on the brain, and that's really awesome. For me, I do a specialty called functional neurology, and we really try to work on some more of these brain inhibitory pathways. Sometimes we use adjustments to our advantage, and we use that as a tool. We use other things as well to kind of tap into those parts of the brain that aren't inhibiting pain and inhibiting these different conditions that people have going on, because those are the ones that are a little bit more difficult. I think we're finding more and more with patients that it's not these simple low back pain cases anymore. There's a lot of concomitants going on. There's a metabolic thing going on. There's a brainstem thing going on. Is their autonomic system out of whack? So these are sort of the things that we have to also think about in getting a patient better, because Dr. Denny and I, we can probably tell you, we could adjust people until the cows come home. But if they've got something bigger going on, a metabolic condition, if their diet is trash, if their brain is trash because they're on 10 drugs or they're drinking all the time, things like that, they've got all these other things going on, that adjustment, it's only going to help so much. So we kind of have to start thinking a little bit bigger and working on some of those other things, those other lifestyle things to get people better. But anyway, I've read this study several times, and I think it's just really cool that we're starting to kind of narrow our focus of research and really trying to figure out what are we doing with an adjustment, because for so long we didn't have a really good way of measuring it. And now with technology, we can really measure what we're doing a lot better. So then we have these descending inhibitory pathways as far as pain goes. And these are really cool because this is the stuff with functional neurology that I like to work with because this comes from the brainstem and the prefrontal cortex. What's cool about our frontal lobes, so most people think frontal lobes, it's our executive function. It's what's telling us to do. But another big part of the frontal lobe is actually inhibition. And it's there to kind of keep us human, really. You know, when people have brain injuries, frontal lobe injuries, then we start to see where their personalities change. They might have these escapes going on where they say things that aren't appropriate in public. They do things that aren't appropriate in public. And that's because they're losing inhibition. And we can see that really with pain too. You know, our body is designed to inhibit pain and inhibit these signals that are coming from the environment and telling us that maybe it's too much for us to handle. And that's part of our brain's job. And so if our brain's not working so well and we don't have these descending inhibitory pathways working well, then we might see where we're having this overload of pain and somebody is just like in severe amount of pain and there's really no reason for it. They don't have that adequate nociceptive input for this perception that they're having. So the cortex is largely part of that. And then we have the brainstem. So we have this periaqueductal gray system. And not to get too much into the neuroanatomy, but through a cascade of events, that system comes down and it also inhibits that pain pathway. And really it does this through this thing called the reticular formation, which is really just our system that's sort of our arousal system. And it really is largely played into our autonomic system. And our autonomic system, for those that people don't know, that's sort of our stress response throughout the day. So it's more of a scale, a push-pull, where throughout the day we either are in this rest and digest phase where our body is relaxed, we're calm, we're doing the things it needs to do, our blood pressure's at an appropriate rate, we're digesting, and you know, we're calm. And then we have the other side, the fight or flight side, which we see people are more and more these days on that fight or flight. They're super stressed out. And when you're stressed, that increases pain, or vice versa. Pain increases stress. So we have to look at that system too and wonder, maybe that system's not working so well. Is their stress response way kicked up, and why? And how do we get them out of stress? So I think another thing that's important for us as practitioners is to talk to our patients about stress and getting out of stress. You know, are they in a job that's putting too much stress on their system? Are there relationships putting them in stress? And how do we manage that stress? But that stress response largely comes from the brainstem, from this reticular formation. And this reticular formation working into that brainstem, doing some of the functional neurology stuff that we do to get that brainstem working a little bit better. This brainstem does some really cool things that really tie into chiropractic. And I think it's unfortunate a lot of chiropractors, they don't know this part about the brainstem. But what's cool about this reticular formation is that when it's firing appropriately and adequately, it's going to, one, inhibit all the muscles in the front of the body above the level of T6 and all the muscles in the back of the body below T6. And really those are just our flexors. So all of our muscles that go this way or bend our legs. And what we tend to see in patients that are in chronic pain is they start to adopt this flexor position. They start to hunch over. You start to see where these muscles tighten up. I'm sure Erica can attest to this in physical therapy, where we start to see all these front muscles, they get really tight on people. And then all their glutes, things like that, those get really tight. And so when we get this brainstem working a little bit better, if we tap into that with an adjustment or some other tools, we start to see where these muscles will become inhibited, they'll relax. And then we start to see where posture improves. We start to see people come back up to here, normal, which is going to help improve their pain. Another thing it does is it inhibits that stress response, which is cool too. It also inhibits pain globally. And then it also sets something called the gamma motor tone, which we will talk about on the next slide. So we kind of talked about how an adjustment locally will block pain through that pain gate theory, but it's also doing something in addition to that. So that motion that we do with an adjustment, that really quick adjustment, if you've ever had an adjustment, you know what I'm talking about. With the neck, it can be pretty quick. Same thing in the upper back. So when we do that motion that fast, what it does is it fast stretches the muscles right there at that segment. And fast stretching is another technique that we can use in chiropractic to help get those muscles to relax. Because when you take them, or when you fast stretch them really fast like that, it loads those tendons right there, and that quick movement and that fast stretch neurologically resets the muscle. And so then we start to see where muscle tone decreases afterwards. So often I have patients, after I adjust them, they say, oh, I feel looser. My neck feels looser, or my upper back, it feels looser. And that's because the muscles have reset and they're relaxing. Now, it may take a few times for the body, again, to learn and have neuroplasticity and to stay relaxed. We might see where maybe an hour later those muscles tighten back up. It's temporary in the beginning, but with repetition, we start to see where that improves and it maintains longer and longer and longer. And we get this thing called long-term potentiation, where the nervous system starts to learn. And that's really cool. And that's how we start to see people get better. And I'm sure Erica, physical therapy operates on a lot of similar principles. So I'm sure you see a lot of the same results. With repetition, things get better. The body starts to learn. And then lastly, like I said, today is short and sweet. Lastly, I just wanted to go over some guidelines. I talked to Dr. Shaw and the pain management docs not too long ago about what are the current guidelines for low back pain, for neck pain, for whiplash? Because these are the people we see every single day here in this building. We're seeing people with low back issues, neck issues, headaches. Some are coming from accidents. Others, it's an acute situation. And for others, it's something that's been going on for years. So JAMA, the Journal of the American Medical Association, their clinical guidelines from 2017. I think they update these every single year for low back. But in their paper, for acute to subacute low back pain, they suggest spinal manipulation, heat, massage, acupuncture as the first line of therapy. This is what we should be trying first in every single patient. A trial of non-invasive, non-pharmacological therapy initially. Now, obviously, there's cases where things are pretty advanced, certain accidents, people get in catastrophic accidents, and we're a little bit past that point. But for an acute situation, for somebody that hasn't had low back pain before, we should try these more conservative techniques first. Give them a conservative run of 3 months of care. And if that's not working, then we kind of work and explore different options. And same thing for chronic. They said even for chronic pain, a range of non-pharmacological therapies should be used initially. So physical therapy, chiropractic manipulations, massage. We should be trying a trial of these things first to see if whether or not they can get some relief before we go down the route of opiates. I have a lot of patients that unfortunately, I just don't see how they're ever going to get better 100% because they're still relying on those opiates. And that's really what's creating some discomfort for them now, because going through those withdrawal symptoms, I mean, that's painful. To see anybody detox from opiates, it's really, really tough, and creates body pain just as much as, their original injury. So it's just something for us to think about as practitioners. How can we better serve our patients? Can we try some of these more conservative techniques first, and then we'll work our way up if we need to? But I think we're already doing a lot better job of that here. I'm starting to see patients, and chiropractic's kind of their first trial, and they're in chiropractic and physical therapy, and those are the patients I see do the best when they kind of get to the two hand in hand. So that's it for today. I like I said, I wanted to keep it short and sweet about pain and chiropractic, and I hope you learned a little bit about the adjustment today.